the procedure, and then once we engage in the question and answer discussion and comments you want to make, I'll ask you to unmute. But for now, if you could just mute your microphones, and we ask the speaker who is speaking at the moment and sharing the presentation to have their microphones open at that time. So we're starting now at 10, it's 2 minutes past, and we will end at 11. That's my understanding of the times. I've spoken about all the microphones being muted. We won't be doing any verbal introductions of everybody in the room that we would do if we were in a physical, on-site meeting or training session. But we'll encourage you, if you want to, there is a chat box at the bottom of the Zoom window. You could open that chat box and make comments there and greet other comrades in the chat box. There is a Q&A box at the bottom. If you want the questions and comments not to pop up in front of the presentation while the presentation is occupying your screen, I'll suggest that you double click on the chat box and you double click on the Q&A box, and it'll pop out as two floating boxes, and you can shift it aside. It just may mean that you need to make your Zoom screen slightly smaller on your laptop or desktop monitor. So for formal introductions, good morning everybody. I'm Ashraf Raycliffe, the National Occupational Health and Safety Training Manager at the NIOH, the National Institute for Occupational Health. My sense is that most of the participants in the session is familiar with the NIOH and the NHLS, so I'm not going to go into any details there other than to immediately go over to the program. And thanks to the epidemiology and surveillance section and the head Nisha Naika for putting all of this together and having done all the background work. My understanding is at the request of NEHAWU representatives, and that representative is Slindile Mbele, who I understand might be a NEHAWU staff member or perhaps be based at the NHLS as well. Our program, as you've all seen, dealing with a discussion on COVID-19, healthcare workers surveillance, and this is for NEHAWU representatives in particular, deals with the following. It's my welcome I've just busy with, the introduction that will follow next by Nisha Naika. Then we're going to ask Comrade Comrade December Mavuso to do a word or two on behalf of the union. That'll be followed by the DATCOV Sentinel Hospital Surveillance System presentation by Wasila Jasad, and then by the results from the DATCOV surveillance system by Lusanda Mazibuko. Then the importance of surveillance will then be addressed again by Nisha. We'll have that question and answer session later on, and hopefully we'll have approximately 20 minutes or so for that. So without much ado, I'm going to hand over to Nisha to just do the introduction. Thank you, Nisha. You can unmute. Over to you.
Thanks, Ashraf. I'm just going to share my screen quickly. Good morning, everybody, and thank you once again for NEHAWU for allowing us to do this presentation, requesting this presentation. I'm just going to be just a quick introduction to this session, and then I think Comrade Mavuso would like to say a few words as well, and also at the close of this meeting. This is just a program that Ashraf has just mentioned. So just a quick intro into all of this is that, I mean, all of us know that protecting healthcare workers is essential to safely maintaining the healthcare system in South Africa or globally. And healthcare workers can be affected through various pathways, either traveling to or from work, at home, in their communities, at work, while working with contagious patients if they're I'm not protected from infected co-workers, from contaminated environments, clinical or elsewhere. So currently, from the notifiable medical conditions database as of 5th July, so it's not up to date, there were 1,892 healthcare workers with positive results, that being about just under 1% of all the positive cases in the country at that time. And unfortunately, we've seen daily reports that these cases are increasing. But I mean, they are internationally, and locally, there are literature and other evidence that there are signs that healthcare workers' infections particularly can be prevented by the appropriate use of PPE, hand hygiene, and other measures like distancing, which have been advocated for everyone, basically. So, but in order for us to understand the problem, or the extent of the problem, to understand what are the risk factors for healthcare workers in particular getting infected, and to determine if the preventative measures that we have in place, are they effective? And if they're not, what is the problem? Surveillance is essential. And so following Comrade Mavusa's opening, Wasila is going to talk about the surveillance system and how it came about and what kind of data the overall surveillance system is collecting. And Rusanda is going to highlight the results pertaining to the healthcare workers in particular. So I'm going to just hand over now to Comrade Mavusa to take over. Thank you.
Comrade Mavusa, you must just unmute your microphone, and you can activate your video feed if you're comfortable with your bandwidth.
Okay, thanks. This system says I can't activate my video because the host has disabled it. So I guess I'll have to.
I will see what I can do on my side.
Now
Okay.
you can share it. You can share it. We give him rights. Yeah.
Thank you. That's our
Okay.
colleague Glenn in the IT department. That's his sister. Thank you, Glenn. You may proceed, comrade.
Okay, no, thanks, and good morning to everyone. I was just trying to see if we have everybody from the union side who's supposed to participate. We're supposed to have all our provincial secretaries in this seminar, and the team from head office, which is they are members of the COVID committee that we established right at the beginning when the lockdown was introduced in South Africa to help us deal with the issues related to COVID-19. So I'll proceed from the assumption that all comrades are here, and perhaps others may still be joining because I can't see that from my side. And really appreciate the convening of this training seminar. You correctly indicated that it was initiated by the union. Our policy unit led by Comrade Sydney and health researcher Comrade Lindy have been working on this particular arrangement. I must also perhaps just tender an apology on behalf of the General Secretary, who would have wanted to be here, but also because of commitments, so he could not join us. So just to start and say that COVID-19 has and continue to inflict unprecedented life-changing circumstances for the entire society. Now in our country, the virus is reaching its peak At the same time, we're in the middle of the winter season, which is known for the influenza, that always affects all of us during this season. The community infections have been increasing exponentially, with Gauteng being the first province to register the 100,000 mark in infections. At the same time, our members who are frontline workers in the fight against this pandemic have not been spared. We've seen more and more frontline workers, getting infected on a daily basis, and some have already lost their lives. And I believe that this training is about, sharpening our response to this virus, and as far as it affects the frontline workers who are members. Sometimes there's an issue about the correctness of the statistics or the data in terms of the infections. I'll come later about just briefly about our assessment and our observation when we visited some institutions, because there's an issue of transparency and lack of communication that is part of the problem here. The policies, which we call it neoliberal policies, have compelled nation states to outsource important components of healthcare, reduce its workforce, and cut overspending in the social functions of states. And these neoliberal economies in many countries are exposed as being unable to produce enough masks and PPEs for their healthcare personnel, not to speak of ventilators to keep hospitalized population alive. At the beginning, and we're told the problem is being resolved now, NHLS has been struggling, to source enough test kits. Well, the other day when I was speaking to NHLS, I was told that it was also because of Trump policies that would not allow them to import, these test kits in big numbers. But we're made to believe that that problem is being resolved. The union, right at the beginning of the lockdown, raised the issues of workplace safety and protection of healthcare workers. And it had to take a court threat from our side to get the attention of the minister to discuss and address these issues. Already, the infections were very low at the time, but there were danger signs. Health workers were scared. There was anxiety, and they felt unprotected right at the beginning. And the issue of their protection, their PPEs, was a big issue. But eventually we met with the minister. When we met, we agreed that the procurement of PPEs and the availability of stock must be matched with the headcount of the different categories of healthcare workers and the type of work they are doing. It was agreed that no worker shall be forced to work without proper and sufficient provision of PPEs. And when you feel unsafe, you will not be forced to work. The department also committed to expedite the process of establishing occupational health and safety committees. And those committees are committees that are supposed to be joint employer and employees committees to deal with the issues of risk assessment, identify hazards, implement prevention and control measures, including dealing with the whole issue of PPEs, and so on. There was agreement that, because we were the Minister of Employment and Labor in the meeting, there was an agreement that the Department of Labor through its inspectorate, will deal with the issues of compliance with Occupational Health and Safety Act, and that there was going to be education and training of workers in general, in the health sector, to know how to protect themselves. But I can tell you now that 3 months down the line, some of these issues, if not all of them, they still a problem. Whilst the infection rate is increasing, the issue of the protection of the health workers is also a big problem. We can agree that to a certain extent, yes, PPEs, there has been improvement, but because of lack of proper planning in many areas, you still find shortages of PPEs for the protection of these health workers. That's why they are getting infected on a daily basis. We undertook a program as leadership of the union the past 3 weeks to visit the 4 epicenter provinces and identified institutions just to assess the situation on the ground. And we can confirm that really we still have a problem. Like I said, there's issue, first, just a few of the observations. The issue of a lack of communication and transparency is a big issue. And this is because there's no involvement of workers in the decision-making, in the planning, in dealing with COVID. Because you can only do that inside the occupational health and safety committees, despite the agreement and decision taken with the minister, despite the directions issued, the regulations by DPSA, employment and labor, for all workplaces to establish these occupational health and safety committees. Many institutions don't have them. And when we listen to members, they tell you that the decision-making remains that of management regarding this particular matters. So even when there are infections in the hospital by health workers, there's no risk assessment reports you will find. You would not see what the prevention and control measures that have been implemented. And these are things that we need really to deal with. So there's a lot of anxiety and fear amongst the healthcare workers in our country. But the other observation, and which is something that is not new, is a leadership problem that has been exposed by COVID-19 at the workplace. Many of our hospitals are suffering from leadership problems, and we hear the minister, the MEC is talking about using this opportunity to really lay the ground for NHI and so on. But as long as you don't really deal with the practical issues in the workplace, including the leadership question, you will not really achieve the NHI. So the leadership problem or challenge leads to these issues of PPEs because there's lack of planning. There's issue of hygiene and dirtiness in many of the hospitals. But some of these issues are because of the huge shortages of staff, of cleaners, of porters, and so on, nurses, doctors, and so on. The other issue is there's inconsistencies in the application of standard operating procedures across the sector. People are redefining the status of being a contact, refusing workers to isolate or quarantine or reduce the period or shorten the period of isolation. People are forced to work even after they've tested and so on. So those really are some of the issues. So we have just finalized our report. We are, as a leadership of the union, preparing meeting with the minister to deal with some of these issues. But as I say, I hope that this workshop, this training will help also sharpen our approach and our strategies. And we appreciate the fact that we're here today. And thank you very much, Program Director, for the opportunity. And hope we have a successful, engagement. Thank you.
Thank you very much, Comrade Mavuso. We appreciate that the Deputy General Secretary has been available for this. I can quickly share with you a screen with the names of those people who are online at the moment, if you want to quickly have a look at that. In the meantime, I'm going to ask our next speaker just to prepare the slideshow, and maybe I can show the names later on. So at this point, I want to also just welcome the Executive Director of the NIOH, Dr. Spo Khalamono, to the meeting as well. Thank you for joining us, Dr. Spo. I now hand over to Dr. Washila Jassat from the NICD, National Institute for Communicable Diseases, to deal with the DATCOV Sentinel Hospital Surveillance System. Thank you. Please proceed.
Good morning, everyone. I'm sharing my screen. Hope you all can see that. First, wanted to just share that I really appreciate this invitation to speak with you today and to express my support for all that was said by Comrade Mavuso. I think it's a very important issue. And we at the NICD are very keen that our data is used for action. You know, there's a lot of information available out there, but how it informs our plans and actions is what's most important. So I've been invited to share a little bit about the Sentinel Hospital Surveillance for COVID-19 that was established at the NICD, led by Prof. Lucille Bloomberg. So the purpose of the surveillance was to describe the epidemiology of COVID-19 in patients admitted to hospital in South Africa. So we wanted to first look at the profile of the patients to describe them so we could understand who is this disease affecting and which people have poor outcomes. And secondly, we wanted to look at the distribution of the hospital admissions. Where are they admitted between the different provinces, between the public and private health sector? Are the patients in ICU or general wards? Do they need ventilation? And the purpose of this was to look at resource demands and where resources needed to be allocated. So I thought I'll share a little bit with you about the data collection. The things we collect on the platform is some demographic information like age, sex, and race. Some information about comorbidities, so this is the underlying medical conditions like hypertension, diabetes, HIV, etc. Some complications they may develop, like the lung complication that many patients have, ARDS, kidney failure, and others. Some information about treatment, other patients getting steroids, high flow oxygen, ventilation. Where are they being treated, in ICU, high care, or general ward? And what are the patient's outcomes? Have they been discharged, transferred to another hospital, or died? So we currently get our information either from people using our online platform. So we have 34 public hospitals and 35 private hospitals using our platform. And then from all the private hospital groups and from all the Western Cape public hospitals, we get an Excel upload, and all this information feeds into our online platform. So at the moment, we have, by the 12th of July, over 23,000 patients admitted, recorded on our database, and over 300 hospitals in the public and private sector. So I thought it was important, even though Lusanda will share with you specifically the healthcare worker data a bit later, I thought let me share with you information about all admissions so you can see what the trend is in South Africa with hospital admission, and also who is most affected with death from COVID-19. So in this graph, you can see from the first week of the outbreak, which is epidemiological week 10, until the last week, the increase in the number of hospital admissions in the public and the private sector. And you will see that there are more admissions in the private sector recently. In this graph, you can see the difference in admissions according to provinces. So you'll see that the Western Cape had a sharp surge in admissions a few weeks ago. The surge has started in Gauteng, in Eastern Cape, and also in KZN now. Here you can see who is admitted by age and sex. So you'll see that it's mostly people of working age in the middle age groups that are admitted in hospital, although we've had about 4% of admissions in young children under 18, and more admissions have been in females. This table shows you of all the patients that we have information on, what were the most common underlying medical conditions. So you'll see that hypertension and diabetes were the most common, but we also have almost 2,000 patients admitted with HIV who have been diagnosed with COVID, and 400 people with active tuberculosis. For all the patients that were admitted, 60% were either discharged or transferred out to a step-down hospital, 14% died, and 26% were currently still in hospital. Now you will see that the number that we have is less than what's reported by the minister, and that's because we don't have all hospitals reporting to us. This curve shows you the deaths since the beginning of the epidemic, and you'll see there's been an increase in deaths in the last few weeks, and that more of the deaths have been in the public sector. Here you will see the deaths by province, and you'll see the biggest number of deaths in the Western Cape, followed by Gauteng in the Eastern Cape. This is a breakdown of deaths by age and sex, and you'll see here that there are more deaths in people who are older than 50 years, but that there are a fair number of deaths in people younger than 50 as well. And when we do analysis, statistical analysis of what is associated with mortality, we find the same as what's reported in other countries, that older age, male sex, having multiple underlying medical conditions, and specifically the following medical conditions: hypertension, diabetes, chronic heart disease, chronic kidney disease, cancer, HIV, and TB are all associated with mortality. So of all the patients admitted, the patients who had these characteristics were more likely to die. The other thing that was, the other things that are important in this data is that while other countries have reported on some of the other the risk factors, for the first time we're seeing that there are associations with HIV and TB in South Africa. We're also seeing that there are a number of pediatric admissions and a few deaths, whereas in other countries they did not report many pediatric deaths. And I think also important to remember, even though there's a higher risk in older people with comorbidities, there have been some deaths in people younger than 65 with no comorbidities. What our data is not that able to report on are the following. So obesity, we know from other countries, is a huge factor that's associated with death. We don't have it very completely recorded, but where it is available, almost 50% of people who were said to be obese died. We also don't know for conditions like diabetes that are these patients newly diagnosed or did they have diabetes before this? And we also don't know how well was their diabetes controlled. So these information are just not available in our database. We are trying to improve our data on HIV, things like viral load and CD4, so we can look at that in more detail. And then maybe just to touch on a few points at the end. We believe that the surveillance is very important. It gives us real-time data, and it provides us with reports daily that we send to each province and to national, and we're able to do a more detailed analysis every week. And I think this data addresses a knowledge gap. So there's lots of publications about COVID in high-income countries, but there's still many unknowns in the South African setting. And I think the surveillance is useful to answer questions in terms of using data for action. So who is most at risk? What should we do with patients who have non-communicable diseases and HIV and TB because they are at high risk for death? What guidelines should we have for managing COVID in high-risk groups like healthcare workers? What interventions and medications have been working, and where should our resources be targeted? I want to also share that there are some limitations to our surveillance system. As I said earlier, this is sentinel surveillance, which means that it's a selected number of hospitals. So currently we cover all private hospitals, but only about 80 public hospitals around the country, out of a total of 330, I believe. So the reason for this is that not all hospitals, all provinces have been able to sign on to use our platform, but I believe that the minister has urged all provinces to use the surveillance system. So hopefully we will soon be getting more complete data. Also, this system only reports on hospital-based admissions and deaths, so we won't know about deaths that might have happened outside of hospital. And finally, the data quality is dependent on the information that is submitted to us. And so we acknowledge that there might be issues, and we try where possible to improve the data. I'm happy to share this presentation to all, and that's our email address if you have any questions. Thank you for listening.
Thank you very much. And that was Sheila with, I think, the important presentation on what the DATCOV Sentinel Hospital Surveillance System offers, some of the limitations. And I think it's important for you also, obviously, as NEHAWU, as trade union representatives and representatives of your constituencies, to be familiar with this. I'm going to immediately hand over to Lusanda Mazibuko, who's going to deal with the results from the DATCOV surveillance system. Please, if you could just share your screen, Lusanda.
Okay. So, okay, just a minute. Good morning, everyone. I'm Lusanda. I am responsible for analyzing the healthcare workers' data. Okay. All right, I'll just give a brief summary of results on what we have been observing on healthcare workers that are recorded in the DATCOV surveillance system. So, as of July 12th, there are about 597 healthcare workers that have been recorded in the DATCOV database system. That is 2.6% of the total COVID-19 hospital admissions that are recorded in the DATCOV database system. So the information on healthcare workers has been reported from 122 facilities across all 9 provinces of the country, 18 of which are public sector facilities and 104 are private sector facilities. So there was a total of 164 healthcare workers who had available data on the type of work that they do. And the majority of healthcare workers that have been admitted are nurses, porters, allied healthcare professionals. So there's about 82% of healthcare worker admissions that have been reported in the private sector. However, we are seeing an increase in our reported admissions in the public sector as well. So the most admissions that we have observed amongst healthcare workers are reported in Gauteng Province, KZN, and the Western Cape. These provinces account for a combined 78% of the healthcare worker admissions. The average age of healthcare workers that were admitted is 45 years old, and there was 58 admitted healthcare workers that were aged 60 and older, and 78% of admitted healthcare workers were women. So this is a breakdown of what I have been talking about. You can see that the private sector has a large number of admitted healthcare workers, but there's also an increase in the public sector as well. This is epidemiology. This is admissions by week, and you can see that since May 31st, around June, there has been a very much increase in admitted healthcare workers, and I guess that follows the national trend because we have seen from Wasile's presentation that there has been an increase in the national admissions as well. So these are outcomes for healthcare workers. Currently, there are 410 healthcare workers that have been discharged alive. 153 remain in hospitals and 7 have been transferred out. So the data that we are reporting here for deaths is as of July 5th. The reason is because we have to take an additional step in our verification process to verify healthcare worker deaths to make sure that we are reporting on accurate information. So this 12th July deaths are not yet verified. Therefore, we are reporting on the ones that we have verified. So as of 5 July, there were 17 deaths amongst healthcare workers. And And then the deaths made up 3.6% of the data that we have seen on healthcare workers. And the case fertility rate for healthcare workers was 6%. It is much lower than the case fertility ratio that we have seen in all admissions recorded in the database system. So 6 of the deaths that were reported are from the Western Cape and 4 are from Gauteng. The median age of those who died was 62 years old, and 82% of the healthcare workers that died were women. Of those that died, more than 70% had at least one comorbidity reported, and hypertension and diabetes were the most common comorbid diseases that were reported amongst those who died and amongst admitted healthcare workers. So in conclusion, as we've seen, admissions are increasing weekly, keeping up with the national trend of admissions. And those who are most at risk are the healthcare workers that have comorbid diseases and those who are aged 60 and older. Thank you for your time. I hope this has been helpful.
Thank you very much. That was Lusanda Mazibuko from the NIOH's Epidemiology and Surveillance section, dealing with the results from the DATCOV surveillance system. And it gives you a sense of what that sample makes available in terms of useful information, not just for analysis, but also for planning and determining what your interventions are. The next topic is the importance of surveillance by Nisha Naika. We are running slightly late, but we will still have some time for question and answers. Over to you, Nisha.
Thanks, Ashraf. I'm just going to give a few remarks on that because I think Wasila has touched quite a bit on it, and Lusanda has touched on it as well. And just the most important point is that surveillance is important, and surveillance data is very valuable in that it will show us where the problems are and what resources or how much of resources will be needed and where it should be targeted at, and as well as whether the interventions that we put in place are working and why they are not, if they're not working, why they're not working. And I think, but one of the critical issues is the quality of information that we are getting. As we can see from Wasila's presentation and from Lusanda's presentation, all the data is not coming through, and quality, and it's essential that the people at the hospitals, the data captures at the hospitals, the people filling in the information in the patient's charts, etc., are filling in the information correctly and completely for us to get the data that is required in order for decisions and guidelines and policy makers to be able to use complete and quality information when changes are needed. And I think that's from me, and I'm gonna I think Comrade Mavusa would like to say a few more words possibly, and I'll hand it over to you, Ashraf.
Yes, thank you very much for that, Comrade Mavuso. I see that you're still online. Do you want to just make some comments now or after the questions and answers opportunity?
No, I suggest we take the questions if there are any.
Okay, so thank you for that. Thank you for that comment, Mavuso. I will now open the floor for any question answers on the presentations that was presented by Washila Lusanda, and both the introductory and comments made by Nisha about the importance of this data, considering the nature of the organization. It's a labor organization, and you represent an important frontline constituency in the public health sector and private health sector. You can, if you want to, raise your hand. There is at the bottom of your screen a function where you can click to raise your hand if you want to do that. At the moment, we have about 25 attendees, Comrade Mavuso. And so if anybody, I see Comrade Sydney Khara as his hand up, and Siabonga Kobese. Comrade Sydney, you may proceed to unmute your microphone. Comrade Mavuso, if you could just mute yours. Comrade Sydney, you can proceed.
You heard? Hello? Yes.
Yes, we
I
can hear
wanted
you.
to. Oh, thanks very much. Yeah, I appreciate that the survey is still developing in a sense that it's not covering all facilities yet, but it's nonetheless very strong sample of what's happening. But it's also maybe an issue I want to check the NIOH is considering to, to plot the relationship between the high incidence of infections per institution or province in relation to the implementation of health and safety in those institutions. There has to be a relationship in that regard, since your organization, that's part of your main functional mandate. But I also know that you're largely, that is, the occupational health and safety is largely dealt with by the Department of Health. But I think it should be a consideration in terms of the results. That it's not just how many people are infected, but where there's higher infection, what's happening in those institutions. Thank you.
I'm going to suggest we take Comrade Slindile's question as well, and I thought I saw another hand earlier, and then we can ask Nisha and colleagues to respond to you. Please proceed, Comrade Slindile. Just unmute your microphone.
Hello? Hello?
Please proceed. Is that
Oh,
Slindile?
okay. Oh,
Yeah.
yes, it is Lindile. Thank you, Ashraf, and thanks to the presenters for the presentation. Okay, my question will be on, I just wanted to find out if the data also looks into these areas of infection, especially between these 4 provinces that are the epicenters, if it also looks into between urban and rural areas, the infection rates between the 2 areas. Where do we find higher infection, with an understanding that you're not getting data from every hospital, but have you looked into the different areas and where you get more infection, especially with the rural areas, as we all understand that they are mostly disadvantaged with infrastructure and other resources for them to actually be able to attend to cases of COVID-19. So how is the infection between the 2 areas, urban and rural? Thank you.
Thank you for that. I invite Comrade Siabonga, who's raised his hand, just to unmute and then ask his question or make his comment.
Yes, I hope I'm audible.
You are now audible. Please proceed.
Yes, thank you very much. Thanks for the presentation. It's quite an interesting research, which is what we thought is very important for us to do, especially in relation to the frontline workers. However, the concern though is that the numbers that are referred to, we believe that they are not a true reflection of what is happening on the ground. Perhaps it's because they are focusing mainly on the frontline workers that are hospitalized. But I thought our interest is not only those that are hospitalized, but generally the infections of frontline workers in hospitals. That could be something that we'll have an interest on if you could also expand to that. Because there are infections in the Eastern Cape where I am. By June, we had close to 872 workers who were infected. But of course, there were no categorization whether they are hospitalized, others, and how many we have recovered so far. The second aspect is in relation to what was also mentioned in terms of the types of work that they are doing, because we are not sure why the infections is so high in the frontline workers at the moment. So it will be imperative, if you may, as the research is still ongoing, to further look at the types of work that the frontline workers are doing, so that we have an understanding of why the infections is so much to frontline workers. Is it mostly for those that are dealing with patients, or is generally for the frontline workers that are in hospital, so that we're able to have an analysis whether the PPEs are adequate or sufficient enough to prevent the infection. Thank you so much.
Thank you for that, Comrade Siyabonga. I don't see any more hands. I'm going to ask the panel, that's Nisha, Washila, and Lusanda, just to respond to the, I think, 3 questions we've had, 2 by Comrade Siyabonga. Could we start with Comrade Sydney's question?
I can go if you'd like. So I think it's a very important question. We're reporting on the trends, but it's important to understand why. And so, your comment about relating the incidents to the health and safety, I think, is quite important. The Department of Health is meant to collect information about PPE. And I know I just had a call yesterday with the head of health in Northwest, and they were quite concerned about the reporting and the transparency for that reporting. And they've asked that our platform be used to capture information weekly on PPE available in every hospital. So, while I don't have the answers for you, I wanted to respond that the provinces are quite interested, and National is interested in collecting information about PPE. And once we start collecting that from the hospitals, we may be able to look at whether there are any correlations, where there are higher incidence of healthcare workers affected with the availability of PPE. It's always going to be difficult to make those kind of analyses, but I wanted to reassure you that this is something that the department is collecting, and they've asked us to support them in collecting and analyzing as well. Would you like me to answer on the other questions, or first have the others?
If you want to add anything on the other questions, please proceed.
Thank you. For Selindile's question, I think also very important. I think looking at the urban and rural divide is really a worthwhile effort. At the moment, all the hospitals reporting to us are either private hospitals or the big urban centers in the big metros. So we have hospitals in some of the more rural areas as well, Manguzi, Madweleni, and others, but they're much fewer. So once we get more hospitals on board, we will be able to report on this. I think the other important thing is also differentiating. So we differentiate between provinces and between public and private sector. It will also be important to differentiate between the levels of care. So tertiary, secondary, and district hospitals, because we know that the capacity for critical care will not be the same at smaller rural hospitals. So in future weeks, I will also include this in my analysis, looking at the differences in mortality between urban and rural areas and between the different levels of hospitals. So thank you for that comment. And with regards to the questions from Siyabonga, agree that this is not a true reflection of the cases. And I think Nisha and Lusanda can talk more about the total number of cases, because I mean, our system is only looking at hospital admissions. So I'll leave that one for them to answer. And in terms of the types of work that the patients are doing, at the moment, you know, the hospitals report just on the category of healthcare workers, so whether they doctors, nurses, lab staff, admin staff. It's difficult to get more detailed information, but I think it is important. Anisha may know more, but just anecdotally what they are telling us, it seems like the healthcare worker transmissions are more community transmissions than they are in the healthcare setting. But I mean, I'm not sure if that has been looked at and definitively answered. Anisha may know more.
Thank you for that, Washila. I'm going to hand over to Nisha and to Lusanda for the other questions. Just to note that we are running short of time, and I'm not sure if I can ask your permission to extend it by, say, another 5 minutes, because we have 3 questions in our Q&A box as well. Nisha, over to you.
Yes, thanks, Ashraf, and thanks for the questions. And I think Wasila has addressed quite a bit. With regards to Sydney's query on the relationship to health and safety, I mean, as if when Wasila collects the data, we will be able to do some of that analysis, but it's going to be related to PPE only, as what I understand. In addition, there are 2 weekly meetings, or every 2 weeks, there are occupational health and safety meetings with the public and the private sector run by the Department of Health, where provinces do report on occupational health and safety measures that are at hospitals. And we are in the process of asking them to, or requesting from them to also send this information to us so that we can include it in our analysis. So when that does materialize, we'll be able to answer some of the questions. And I mean, it is quite important that we relate the number of, or the incidence of, or prevalence of the infections with, you know, the measures taken to prevent these infections, so we can see whether they work or why are they not working if the infection rate is going up. And I think at the moment we are not able to differentiate between the urban and rural, but as soon as we get the data from the DATCOV database, we will be able to do that. At the moment, our cases are increasing, but you know, to make those kind of associations, we will need more information. With regards to the Siyabonga's question on the type of work that is, you know, what work are healthcare workers doing that contributes to the high infection rate. This, you know, in the database, as Wasila said, there is the category for healthcare workers, and they could stipulate what type of work they actually do, whether they are a nurse, doctor, porter, admin staff, etc. But again, this field is very poorly captured, or the data is not supplied, and making it difficult for us to do that sort of analysis. Lusanda would have, in one of her slides, would have mentioned that only about 25% of all the cases that have been hospitalized, do we know what type of actual work they are doing. And some of the hospitals, I mean, in addition to the DATCOV database, some of the hospitals might be using another tool, the WHO healthcare worker tool, that really describes, if they're using that tool, describes the type of work the healthcare worker was doing if they were exposed at work, whether they were assisting a patient, a positive patient, whether they had PPE in place or were using PPE when they with assisting the COVID positive patient, etc. So, some of this information is being collected, and it's very, it's not distributed to all the hospitals at the moment, and this is something that we would advocate for, that hospitals, especially the occupational health and safety departments, try to collect as much information as possible. And if we get access to that information, or when we get access to information, we can then analyze the data appropriately to provide the information that will inform policy and guidelines, etc. So I think I've covered most of the questions so far. I'm handing to you, Lusanda, if you want to say anything else, or Ashraf.
Sanda, do you want to add anything to the questions or any other additional comments following your presentation?
Okay, I just maybe this Sewonga's question about the type of work and high infection rates. We have observed from the work, from the data that we have, that nurses and porters are the ones mostly infected. And although we are not yet sure, and it's important that we are sure of what really is happening and what is leading to this high infection rate, those are people that we have noticed actually are exposed more to COVID than others. I guess the other questions have been answered.
Thank you for that, Lusanda. I'm going to direct your attention for a moment, and it's 2 minutes to. Can I just for one moment just ask Comrade December and Nisha if it's okay if we extend by, say, just another 5 minutes? Otherwise, we won't be able to cover Nobukosi, Casper, and Sydney's last questions. Is that fine?
Yeah, it's okay. Let's do that.
Yes.
Nisha, sorry? Okay, thank you very much. So if you look at the Q&A open box, if you haven't opened it yet, just double click at the bottom. You'll see number 3 in a little red box there. One question was answered just now, and that was Sheila answered Casper. You'll notice there, his question was, collating of data is an important exercise, noting the system you have in the Western Cape. And you can read the rest of the question there, and then you'll see was Sheila's answer that the National Department of Health has given guidance to provinces to submit data. We are in the process of rolling out to KZN, Eastern Cape, Northwest, Free State, and engaging with other provinces. Sydney has responded as well. I think the union must demand that all hospitals must submit their records to the NIOH surveillance. And December has commented on that, certainly. Okay, so that's a comment. The open question we still have is from Comrade Nubukosi. And the question reads, it appears that there is a need to develop a medical surveillance questionnaire that will assist in determining existing comorbid conditions in healthcare workers. This information will assist in improving or strengthening treatment protocols as control measures to reduce the risk levels, and probably inform risk management plans in a form of protocol specific to healthcare workers. Most facilities do have occupational health clinics, and these clinics should be able to monitor compliance with chronic disease management. I'm putting that to the panel. It's more of a comment, and it might inform the earlier point made by Comrade Sydney about a union-based effort interventional campaign supported by Comrade December. Any comments on that panel? Washila, Nisha, or Lusanda?
Hi, yes, it's Nisha. I agree, and I think the occupational health clinics are well placed to be able to monitor the chronic disease of the healthcare workers within their facilities. And I would assume that even if it's not the occupational healthcare or occupational health clinics at the facilities, chronic management of the disease could be done with whatever healthcare provider that the person or the patient or the healthcare worker is associated with, and most healthcare workers are part of would have or are part of a medical scheme that is paid for from the Department of Health. I would assume so. But I agree that monitoring and compliance with medication for chronic disease management is essential at this stage and normally as well. Let's see.
Thank you. If I can add, maybe just, it's important to understand the key messages here. We're sharing who is most at risk for mortality, and we know that healthcare workers are at risk by nature of their occupation, but they are also at risk because of demographic factors like age and sex and comorbidities. It's interesting to note that 10% of the admissions were in people over 60 years of age. So I think we should be thinking about, risk stratification and protecting those that are older from high risk exposures. We should be protecting those with multiple comorbidities. We should be protecting those with particular comorbidities that we know are associated with death. And also importantly, I think what we should also realize, and it's something that can feed into the occupational health monitoring and surveillance, while we're saying that things like diabetes are associated with severe outcomes for COVID, we know that in South Africa, there is a very high proportion of people with undiagnosed non-communicable diseases. So many people are walking around with hypertension and diabetes and they don't know it. And they are presenting to hospitals with coma and, very, very high sugars and in diabetic ketoacidosis. And they never knew they were diabetic. So I think there's a hidden silent risk here as well. And what this means for us is that, for healthcare workers to have screening for diabetes, and then for those at a high risk to monitor their symptoms more strictly, and to present for testing if they have any symptoms. So I think let's think about what this data means for how we monitor and support our healthcare workers. Thank you.
Thank you very much for that. Any final words perhaps from you, Lusanda?
No.
Okay, thank you very much. So at this point in time, I'm going to ask Comrade December if he wants to make his final remarks, unless I do still see Comrade Siyabonga's hand up, but I think that was for an earlier question. There doesn't seem to be any other Q&A questions other than what we've dealt with. And there are no comments in our chat box that requires our immediate attention. So I'm going to hand over to Comrade December. Please proceed.
Yeah, no, thanks. Thank you very much. Let's once again appreciate the engagement, and I hope that this marks the beginning of a working together with your institution, especially on these issues of occupational health and safety. Just to come to a few things. Firstly, I'm not sure if you know how many institutions are treating COVID-19 patients, because I was surprised 2 weeks ago when we arrived at George Mukhari Hospital. We were told that that hospital is not yet treating COVID-19 patients. They are all transferred to Tshwane. It may be important out of the number of hospitals that we have, just to get a sense of how many are treating COVID-19 patients. Maybe the reason why you're not getting their feeding data to you is because some of them are not yet treating the hospital. But the issue of working together with the occupational health and safety committees and practitioners in the institution is going to be important. That campaign Comrade Sydney spoke about. The union reps there are going to have to make sure that we force cooperation. I saw at the Leratong Hospital when we were there that it is one of the institutions that is feeding data to you guys. But we're going to have to run a campaign, as Comrade Sydney was saying, to get more and more of these institutions. We will raise the issue with the minister in our meeting that we're preparing for, so that there's greater cooperation. But of more concern, which is something we need to look at, and the workers who are at risk with underlying conditions and so on. I've never had in any institution where different arrangement is made for these workers. We know that it is a talk of, so if you are at risk, stay at home or work from home, and all those things may not be possible for a nurse and so on. But what measures have been put in place and so on. So we don't get to see that. These are things we need to pursue in the protection of these healthcare workers. In the public service, just a few days ago already, EPSA has reported that 6,754 employees are infected, generally in the public service. And this may not be a true reflection, maybe bigger than that, but it's really concerning. But let's appreciate the data information you've given us. I'm sure it would help us, sharpen our approach and work together to really get more information and for planning and for action. Otherwise, thank you very much.
Thank you very much, Comrade December, for those encouraging final words. And I'm sure as trade union representatives, you would have heard the researchers indicate some of the, let me call it, challenges they face in securing more data and the quality of the data, and to be able to answer some of the questions you've asked also related to the link to health and safety, the relationship between this data and health and safety, the limitation that it might only be addressing PPE. And we know that there's an overall occupational health and safety management system you need to consider within the health facilities. As well as that rural-urban question, and then the question by Commissioner Bonga and Nobukosi, Casper, and Sydney, as well as in the Q&A box. And so in your planning, I can only, from a personal point of view, encourage you to consider what the needs are of these kind of epidemiological and surveillance tools that Washila, Nisha, and Lusandas has presented to you, and how in your efforts you can probably assist in making sure that we do have good data sets that can give very useful information for both decision-making, planning and interventions and allocation of resources. And then also in your own activities, I guess that addressing the occupational health safety compliance in the institutions itself, you do have a monitoring role and a role of being able to report to the necessary authorities for monitoring and enforcement, and you need to consider the capacity you have internally in order to do that as well with amongst your frontline representatives in the workplaces. So at this point, I'm going to quickly ask Nisha if she wants to just say a final word, or Washila, Lusanda, if anything they want to add before we conclude the meeting.
Thanks, Ashraf. Now, I just would like to thank all our speakers, Wasila, Lusanda, and Comrade Mavusa, as well as all the colleagues that have joined us today and given us some very important input that we will work on. So thank you, everybody.
I can just, before we conclude, try and share the screen. Comrade December, you asked about who attended. This could also, through, I think, Nisha and our IT colleagues, be made available to you. I just want to quickly give you a glance of the attendance. So if I can get this right, I think it's that one. So I'm not sure if you can see that. Comrade December?
Yes, yes. I can see that.
So that's the 25 attendees, excluding the panelists, which I think has our names and your name and so on. So thank you very much also from the NIOH side, a division of the NHLS, for this opportunity to be able to share some of the data and knowledge gained in the gathering of this information specifically related to healthcare workers. And unless there's any other urgent matters, I'm going to conclude this meeting and discussion on COVID-19 healthcare worker surveillance for you as NEHAWU representatives. And I just probably need to stop the sharing. Okay, so at this point, thank you very much. The meeting was recorded for those who asked questions about the presentations. My suggestion is that you liaise through your colleague, Comrade Slindile, who's been the coordinating with our colleague here at the NIH, Nisha, for any of the post-meeting admin, including presentations that will be shared. Nisha, just to check with you, is there a plan to share presentations and any other data that may be required by now?
Yes, we can share all the presentations. We could go onto our website under our surveillance tab.
Yes, and that's a very important reminder. I want to encourage all of the NEHAWU comrades, please, to visit the NIH website. It is a zero-rated website by, I think, all of the cell phone service providers, and I think 1 or 2 internet service providers. So please visit. It is filled and jam-packed, if I can use that word, with very, very useful resources for you to look at. All presentations of almost 40 webinars, COVID-19 specific webinars we have put onto the website, all presentations, all posters and Q&As or frequently asked questions, as well as other resources around issues of return to work, not just post-lockdown, but as well as return to work for post-COVID-19 illness. And if you're not yet subscribed to our mailing list, please send your request to add your email to info@nioh.ac.za. That is info@nioh.ac.za. And at this point, I'm going to ask you to direct any further questions or admin that you might have via the liaison persons, and to thank you all for joining this meeting. That's the end. Thank you very much on behalf of the NIH and the NEHAWU leadership. Goodbye.
Right.